Hello, everybody. Dear moderators, dear colleagues in the Congress Hall, I would first of all like to greet with all my respect on behalf of Turkish Republic's Ophthalmological Society. It would have been nice to be there alive, but unfortunately, the meeting coincided with overlap with another Congress at this time in Turkey. I will briefly talk about the importance of retinal evaluation before refractive surgery. Well, we all know that refractive surgery is getting more and more popular all worldwide. But we should never forget that eyes undergoing refractive surgery may have inherent propensity to develop retinal complications. So we should also not forget that refractive surgery may further induce supplementary risks for these complications. When we look at the literature, the complications linked to refractive surgery is quite long. But we noticed that actually most of them are are either complications of myopia, of hypermetropia, particularly at high degrees. Actually, not only at high degrees, this is a moderate hypermetropic patient and early presbyopia, and he has been operated 2 years ago with refractive lens exchange bilaterally. And he came with this fundus aspect with a very, very giant tear and complained of a dark shadow inferior. Luckily, this patient could be successfully treated with pneumatic pinoretinopexy and laser photocoagulation. But it shows us that not only high degrees of refractive error is responsible for complications, also these may develop in other eyes as well. When we look at the lens-based refractive surgery for supplementary risks, we first of all see infection in the form of endophthalmitis, and then inflammation by triggering alterations in the vitreous molecular structure, and pseudophakia by inducing morphological changes due to difference of thickness between lens and intraocular lens, and complications such as vitreous loss or posterior capsule rupture may lead to development of posterior vitreous detachment up to 80% after phakic lens exchange. Keratorefractive surgery-based supplementary risks will be first increased intraocular pressure during fixation and may lead to optic neuropathy, glaucoma, choroid infection, and other complications due to posterior segment stretching. This is an important, even though with the femtosecond laser, this intraocular pressure rise is less, but there's still an relatively dangerous increase in intraocular pressure. Other risks for keratorefractive surgery would be inflammation again, and laser shock waves and morphological changes, and this will be, and first of all, when do we suction for fixation? On the contrary to blunt trauma, the axial length elongates, then gets shortened, and then normalized. This increased tension both at posterior pole and retinal periphery which facilitates complications and particularly development of vitreous detachment. Why is vitreous detachment important? We see here with the detached vitreous, there happens occurs vitreoretinal traction, causing retinal tear, and which leads to retinal detachment formation. When we look at the incidence of retinal detachment in literature, in the population, it's about 1 in 10,000 per year. And it is very obvious with these figures, with this data taken from the literature, that lens-based refractive surgery detachment association is quite clear. Whereas with association with keratorefractive surgery is much milder. To see a nationwide study from both South Korea and Sweden, we see that incidence of postoperative retinal detachment after phaco surgery is especially very high when axial length is very long and at young age than 50 or 60, because at these ages there is no posterior vitreous detachment. So we should be give a lot of importance to give to determine short and long-term prognosis and risks and examine vitreous, posterior segment, and peripheral retina. We can we can check the vitreous by ophthalmoscopy, seeing this Weiss ring, or with optical coherence tomography, or with ultrasonography, which are giving our information about the status of vitreous. And another thing would be we should pay attention to retinal pathologies who might create fragility as stria angioids. And here, these patients are vulnerable to every slightest trauma and may develop very serious posterior segment complications. As in this case, lacunar cracks we encounter a lot in high myopia may lead to development of choroidal neovascularization. And when we see a myopic chorioretinal atrophy, we should not forget that, as in this case, it is progressive. Within 10 years, the whole macular area is nearly involved. Another thing we have to be careful is the existence of posterior staphylococcus, because with posterior staphylococcus, the tension is much higher at the posterior pole, and foveacesis, which might lead to formation of retinal macular pole formation. And also, peripheral retina is very important. Lattice degeneration, retinaschisis, and retinal defects. Lattice degeneration is associated with high myopia and retinal detachment, and we should treat these patients if there's subclinical detachment at lattice area and retinal detachment in the fellow eye. When there is no PVD, when the PVD is partial, and lattice degeneration with all. Retinoschisis should only be treated when it is symptomatic and progressive, as in this case, after treating retinoschisis case, which was progressing, it resolved completely with the help of photocoagulation. The retinal defects have to be treated not only at the posterior side, but covering the anterior side as well. And we should follow these patients very closely, because there is a chance of developing a new retinal tear 15% within 1 year. So, take home messages. Refractive surgery corrects only the refractive problem. It does not eliminate the inherent risk of the operated eyes, and may even induce further risks for retinal complications. And we should not forget that young age and high myopia have higher risk for detachment, particularly for the lens-based surgery. Prophylactic treatment should be performed in eyes with pre-existing vulnerable pathologies, and patients should be well informed about the possible complications, and the written consent should be received. We have a proverb in Turkey: losing the bulgur wheat at home on the way to Dimyak for rice. Actually, we should keep this proverb in mind before deciding to perform refractive surgery for our patients. Thank you very much for your patience.
Thank you so much.